Welcome to our monthly webinar on occupational health trends beyond COVID-19. This is Karen O'Hara. I'm the Director of Marketing and Communications with WorkCare and your moderator for today's session. Thanks for joining us. The session's being recorded, and during the webinar, you will be on mute. Please submit your questions using the Q&A function in Zoom, and we'll take all the questions at the conclusion of Dr. Harris's remarks. As you know, if you attend on a routine basis, we do post the recording of the webinar on our YouTube channel and a transcript of all the Q&A session on our website. And during the webinar, Alexis will post the links to those resources for you. I wanted to let you know that we have a special webinar planned for May 19th at the same time, 11 a.m. Pacific, on preventing and managing heat-related illness and fatigue. And it will feature Dr. Sarah Johnson and Kala Early, who is one of our athletic trainer industrial injury prevention specialists. So you'll be getting information about that within the next day. We'll be promoting that via our constant contact database. And since you're enrolled in this program, you should receive that information. So please be on the lookout for that. So Dr. Harris and I just saw each other at the American Occupational Health Conference, the conference for doctors in Salt Lake City, and he's joining us from there. And by a weird coincidence, my son just texted me and said he's got COVID. And my sister's family has all been exposed and gotten sick too. So we're not through the woods yet, it appears. And I'm sure he'll be talking about that. So let me turn it over to Dr. Harris. I just wanted to tell you a little bit more about him first. Dr. Harris is board certified in occupational medicine, and he is WorkCare's consulting medical director. He's been doing the COVID webinars since the beginning of the pandemic in March 2020. And I know many of you are familiar with him and his expertise. So we're always very appreciative to hear what he has to say and helping us stay up to date on everything that's going on with COVID and other trends in occupational health. So let me turn it over to him. Thanks for joining us.
Excellent. Thank you, Karen. And thank you all for joining us once again. As you know, and as Karen mentioned, Karen, sorry to hear about your son and your family here. And unfortunately, that is something that we're hearing more and more of, new cases of COVID nationwide, and it seemingly being more ubiquitous than we're seeing in the numbers that are being reported. And so we're going to dig into that phenomenon. We're going to talk about COVID today, perhaps more than we'd like to, because as Karen mentioned, we're not out of the woods yet. And we really got to figure out and begin to talk about where do we go from here? We're kind of at a juncture where we know that the populace wants to be done with COVID. So the question is, should we be acting accordingly and retiring our strategies of protecting the workforce? Obviously, in the midst of increasing cases, as we'll discuss, there's going to be somewhat of a philosophical discussion, hopefully, that we can have briefly around what we need to be doing next to protect our workforce. So without further ado, we'll jump into it. Thanks if you're joining for the first time. Our format is pretty straightforward. We go over a clinical update in regards to our topic, followed by then getting into the pathology. And as we discuss the pathology today, we're going to be discussing it at a higher level than we have in the past. And the epidemiology in terms of trends of what's going on both in the US and globally, we'll discuss, followed by finally some strategies that may help inform us of how we can approach our workforce moving forward throughout this pandemic. And yes, I am using the P word. I know that there have been officials that have said it's an epidemic now and not a pandemic. But I think there are, in the data, arguments to the contrary. And unfortunately, I don't think we can declare an epidemic nation by nation until we have a lower level of disease globally. So let's jump into the clinical update today. So variants, new risks, question mark, right? Because as we see new variants, we need to understand as we break down what the future of COVID looks like as a result of continued variants. And we've talked about what variants are. We're not going to cover the specifics about the underlying variants, and hopefully we're all familiar with how these variants arise in regards to mutations of the virus, right? What we want to really unpack then is what is the impact of new variants going to look like, more or less, as we move forward throughout the rest of this pandemic until we reach the level of endemic disease for COVID-19. So you may have been with us last time, and we talked about the impact of COVID in terms of overall health and wellness of the population and the risks in terms of diabetes in particular, right? COVID being a risk factor for type 1 diabetes, creating new type 1 diabetes. So we're going to jump into what the topics you may be seeing now are in the headlines, which is the emergence of a new Omicron variant, BA4 and BA5, and it now being here in the US, right? And so when we're talking about these two new variants, we are also understanding that they are evading the immune system even better than the original Omicron and previous variants, all right? And we'll unpack what that may mean for us as well. But certainly these headlines are growing, not just here in the US, but abroad, right? Australia, and certainly in South Africa, where we see a tremendous impact from BA4 and BA5 amongst the highly vaccinated as well as previously exposed from BA1 and population, right? And so let's begin to unpack this from a clinical standpoint so that we can understand kind of where we're at, right? And so we know that BA4 and BA5 early collections in the US, March 30th for BA4 and March 29th for BA5, all right? We know that these samplings and the sequences that were submitted to GIS aid, which is that what I've presented before, the international group that looks at sequencing, believes that these variants may have been here for some time, and we're just now picking them up in regards to the impact to the positive rates that we see increasing. Right. And so as we talk about the impact of these variants, we want to think about, is there a different way to look at risk from new variants moving forward? One of the interesting articles recently published looking at a gender-based population impact, right? As well as age. We've long talked about the impact of severe disease and hospitalization and death based on age. But we haven't really dug too much recently into, is there a distinction of severity of hospitalization and death according to sex, all right? And so let's look at that a little bit more in this study that was conducted looking at and separating population into age as well as sex. And their results in terms of severity from COVID-19 began with looking at number of cases, right? And you can clearly see here, I'm going to use my little laser pointer here. So you can see the pretty much normal curve, right, in terms of distribution for cases in this study. But as we look at then hospitalizations, we see what we would expect, the skewing of the hospitalizations to the right, meaning a higher propensity for hospitalizations with older demographics, right? What we see as well in the ICU, same demographic, but now we start to see consistently a difference here amongst the sexes, right? We see in yellow males and in Black female, a definitive difference in regards to increased risk for males to be hospitalized as well as be in the ICU. And if we look at deaths, we see that same trend. Right. So now we have evidence demonstrating, if we put them both together, here's what the curve looks like. But certainly what we want to be cognizant of is that, yes, there very may well be, according to this report, a difference in outcomes based upon sex, right? And so we take that into mind, and we'll talk about it again as we address some potential strategies for our workforce. But we want to now dig into more regarding the pathology of variance in general, because if we think about variance, right, and we think about, what COVID looks like, the rest of this year and moving forward to the next, 2023 and 24, we have to really understand how to respond and react to variance. All right, because we know that will continue to variance will continue to emerge, and I want to be clear, we should not be, for lack of better way of putting it, freaking out every time there's a new variant, right? We don't want to cause hysteria inappropriately if it's a variant that we have observed to have potential low impact to severity and loss of life, right? And so unpacking that and looking at it from a slightly different lens than we've looked at it before, which was WHO classification. We want to unpack this from the now new US perspective. So the US CDC has classified different variants slightly different than what WHO has, right? And they look at multiple factors, including locality of these variants and the impact specifically in the US. And they break them down into 4 categories: variants being monitored, variants of interest, variants of concern, and variants of high consequence. Okay, and so let's look at each of these. If we look at variants being monitored, in short, these are variants that have been in existence in the US and are no longer necessarily causing significant transmissions and or impacts to the population, okay? And so in essence, these are variants that are historical and will continue to be monitored for re-emergence. But if they're on this list, that means that they're no longer significantly detected in the population. All right, variants being monitored. And obviously we know the litany of variants that we've dealt with and presented here, from alpha, beta, gamma, delta, all the way to mu, right? So these are variants being monitored continuously here in the US. Next category, variants of interest. Now these are variants that are going to be able to cause potential risk for infection, transmission, as well as potential issues with regard to diagnostic impact of detecting, these type of variants. Doesn't mean that they're causing significant widespread impact from a severity and death standpoint, but again, variant of interest means that it's emerged and it needs to be monitored and watched here in the US. Currently, there are no variants of interest as of today, based on CDC. However, I do believe the reason why BA4 and BA5 are not listed is because they are, again, sub-variants of the BA family, if you would, which is Omicron. Okay, so we know, and we'll talk about where Omicron fits next. So variants of concern, this is where Omicron falls in. Variants of concern means that it's widespread, right? And it's interfering with diagnostic targets, meaning that may be difficult to detect with some existing tests, and then substantially decreasing the efficacy of previous vaccination and or previous disease with regard to prevention of symptomatic illness, okay? And then increasing in transmissibility and increase in disease severity is how a variant makes the list in regards to variant of concern. Now, this definition is similar to, again, WHO's variant of concern. However, the locality of the variant is taken into account with regard to the US, all right? And like I mentioned, Omicron with all of its lineages, right? BA1, BA1.1, 2, 3, 4, and 5 are all listed as variants of concern. As we understand, it's still causing substantial disease in the US and impacting hospitalizations as well as deaths. And we'll dig into that as well a little bit more when we get to the epidemiology. So there is a 4th category, right, that CDC has created variants of high consequence, right? And it's this category where the failure to detect this variant with routine diagnostic tests increases the likelihood to be in this category. A significant impact, obviously, to the severity and hospitalizations amongst vaccinated individuals, disproportionately a high number of vaccinated persons being affected would put a variant into this category, okay? And obviously, if we see a variant in this category, we know that it would be a scenario in which lockdowns may be considered again, right? So the most severe category of the variants. Hopefully we never see a variant in this category. And we'll talk about the likelihood of that a little bit here in the next coming slides. So as we dig into the epidemiology, we want to look at trends that are happening right now to help inform us of what will likely happen throughout the rest of the year. And again, how we should respond with regard to our protective measures that we put in place. So as we look at the historical map of the global picture, this is what we presented a month ago. So a month ago, we had declining cases kind of flattened out right here in the US, but we saw cases rising in Germany, Italy, UK had peaked in there dealing with BA2, right? And we also zeroed in again on the US, looking at our recovery from Omicron, right? And so if we fast forward to today, we want to not move too quickly to ignore some historical information that I think is germane to our potential future and how we wound up where we are today with the case numbers that we are, one, capturing, and two, more importantly, not capturing, all right? So let's take a journey into examining one of our favorite countries. As you know, I talk about Israel often historically because they have led the way many times over now in regards to vaccination approaches nationwide, right? And so one of the things I want to zero in on is what has happened in Israel recently over the last several months, and potentially what this may indicate for us here in the US, all right? As you recall, Israel was one of the first countries to have widespread vaccinations when vaccines were first available, particularly with Pfizer. They were the first to do boosts after a full series, meaning 2 shots of the Pfizer. They were the first to do a boosting policy for their general population, right? Started with at risk, then they expanded it to the general population. And they were the first in a broad basis to do a 4th shot for those individuals 60 and older, right? As you know, we followed suit here in the US. So it's only appropriate that we look at how things have fared in Israel, since we have followed germanely their practices in regards to vaccines. And let's learn, hopefully, as we have in the past, from Israel. So zeroing in on their population in regards to their cases that they track. And it's interesting with their Ministry of Health, right? They zero in on still those who are isolating, certainly more granular than we do here in the US. And you can see their numbers here where they are tracking that metric, right? They're also obviously tracking percentage of positive cases as they move forward, which is approaching 5%. And right now, Israel is a little on the decline from their peak, right? So as we look at then and zero in on their vaccinations, they have over 6.7 million individuals receiving dose 1. You can see the numbers here on dose 2, all the way down to dose 4. So obviously, the 4th dose being for only those recommended for those 60 and older, right? And certainly in regards to leading the way, they are still leading the way amongst nations in that regard, right? Percentage-wise, right? But if we look at then now trends here in the US, how are we faring? Obviously, our cases are trending up. we can see that. Deaths right now, we're still on the decline, but starting to trend up as well. We know there's about a 2-week lag between case rising and number of, a 30-day lag between deaths and cases, right? And so appropriately, we probably will not see a increase in deaths for another 2 to 2.5 weeks. Hospitalizations, however, on average have about a 2-week lag between new cases and hospitalizations. And clearly we're seeing a rise in hospitalizations here in the US across the nation, right? And in regards to vaccinations right now, 82% of us have at least one dose. Only 66% of the US is fully vaccinated at this point. And that's going to be very important for, again, how we deal with our populations and how we consider risk of protection of the population as well. If we look then at new cases as of today, as of yesterday, today's figures, we can see that the spike there we saw with Israel and where we are now with the US in terms of our numbers going up slightly, right? If we zero in on Israel, we can see the bump that they had came at a point in which not only were individuals far and away fully vaccinated, but also boosted, right? And so again, number of cases here represented because they were still doing a lot of testing, right? They were testing individuals and nationwide. And that was one of the criticisms or critiques, perhaps, of the tremendous numbers that they saw. In regards to the relevance for us, right, as we look at our numbers, right, we are increasing, but our increase is not as steep as we have seen in the past thus far. Doesn't mean that cases haven't been going up steeply. It only means we're capturing, right, these numbers and reporting them. And so so in terms of being reported, we're talking laboratory mandates, right? Most states have a mandate. If you test in a laboratory and it's positive, that must be reported to CDC, right? In some states, if you do a point of care test, like Texas, for instance, if you do a point of care test at the workplace and it's positive, that must also be reported to the state, right? And to CDC. And so what's not required to be reported, as we all know, are the home tests that are being used ubiquitously now around the nation. And so in some jurisdictions like Florida, we're talking only 1 out of every 10 positive cases are being reported, right? And so again, if we're looking at a 10 times fold potentially of what we're actually detecting, then we are seeing numbers dramatically increase, unfortunately, from likely BA2 as well as BA4 and BA5, right? And so again, as we look historically at waves, I don't have a slide for this, but if we look historically at waves, there is clearly a cyclic nature to our experience and spikes with COVID-19, right? And in terms of specific figures, let me grab one thing here real quick. I'm gonna grab some figures here from an analysis of the nature of our cycle of COVID in relation to our seasonality of also pneumonia and influenza, right? And as we examine that, we can see that in the 2020 season, right? And when I say season, again, I'm referring to influenza season, pneumonia season, right? In that 2020 season, it was about the peak of our experience with COVID occurred at week 16, okay? And then our second peak that year occurred at week 31, right? If we look at 2021, we had our first peak during the first week of that season and on week 36, right? So 35 weeks went in between our first peak and our second peak that season. If we look at fast forward to now, we experienced this peak that you're looking at here, right? On week 3 of our season. And currently, we're only about 17 weeks into this season. So again, it's not far-fetched to suggest that we will experience another spike during this particular season because we've seen a lag or a pause in between spikes before. Again, learning the history so that we can help predict the future in regards to our approach based upon what may happen. If we look at then more globally, other trends that may be important for us, right? Looking at what's happening in Asia and China in particular, we all know they've been hard hit, right? But we want to get granular about what they're experiencing. Are they experiencing new variants that are impacting their population, or are they experiencing simply a spread of what we've already discovered in regards to variants? Because again, that's germane to the impact globally from spread from their tremendous burden that they're experiencing. And what we found, if we look at GIS aid, again, that tracks the genealogy, if you would, or the actual both phenotype and genotype of SARS-CoV-2, it is 6 different genomes that are currently ravaging and been discovered in China, and 44 genomes of Omicron. So the 6 genomes is associated with Delta, and the 44 genomes are associated with Omicron. So no new divergent variants have been discovered in China. Again, good news for potentially not having a spread from China to other locations of new variants in that regard, okay? But what we wanna continue to look at is, what is WHO speaking to in regards to this trend of variants, right? And so WHO has said the most likely scenario, positive news a little bit here, will show COVID severity will decrease over time. All right, and this was just published March 30th, on March 30th, all right? And if we dig into this specifically, right, we can see, based upon what we know, the most likely scenario is that COVID-19 viruses continue to evolve, but the severity of the disease it causes reduces over time, and immunity increases due to vaccination and infection, all right? And this is the director speaking to this, right? However, and this is kind of perhaps a little contradictory, we can still see spikes and deaths that occur with waning immunity. Now, that's not a surprise, right? We've talked about waning immunity and the impacts here in the US in regards to a potential spike again. Remember, January 15th is when we had our last experience of spike, right, with BA1 and perhaps some BA2 there as well. And 90 days thereafter, right, waning immunity is what the population experiences, and that aligned with almost to the definitely to the same week, but almost to the same day of our new increased numbers of cases, right? And we talked about this last month, and we anticipated the increase to have occurred when it did, right? And so again, the future of COVID can go one of two ways per WHO, right? Less severe variants will emerge, boosters will help us, and new formulations of vaccines will help us protect, or we still may see a virulent, more virulent variant emerge, and our protection will wane, and we can experience dramatic impact, right? So those, again, it points out that even though most are suggesting that we'll have less severe disease as we move forward, it is not out of the question that we may still have the emergence of a more virulent variant, okay? And again, that's important in regards to how we formulate our strategies for the workplace and protecting our workforce. So as we then think about then how do we mitigate illness in the workplace, one of the kind of big questions is, should we, right? At this point, is there a need to protect the workforce from what seems to be a low likelihood of significant hospitalization, severity, and death from COVID-19 for the general masses, right? And when I say general masses, I mean those individuals who may not have increased risk for poor outcome from COVID-19, right? And so let's talk more about that, right? There's kind of two factors. One of them we're going to dig into, another we'll talk about on next time, but we want to talk about it in terms of a successful prevention strategy having vision, being able to see the next wave, right? And I'm not talking about crystal ball, right? I'm just talking about likelihoods based upon history, and then effectiveness, enabling the right protective policy at the right time, right? And so let's talk briefly just about the first point, because that's what's germane to what we've been talking about today in regards to being able to see what's next. Kind of 3 points to it, right? We want to look at workforce population screening, followed by population vulnerability, and then local policy preference, right? And so when we talk about workforce population screening, the question is, should we still be doing some type of screening in our workforce, right? Should we still be capturing who is and who is not being directly affected or perhaps even indirectly affected by COVID-19 cases, right? And certainly the best argument to continue to screen the population is the fact that it serves as a potential leading indicator of risk for your population and a leading indicator for workplace productivity, right? If we look at going back to the data that we presented with regard to hospitalizations, right? The hospitalizations right now with regard to CDC is what's being germanely looked at in regards to policies, right? But if we use primarily hospitalization data, and we talked about this briefly several months ago, that is a lagging indicator in regards to effect on our workforce and the productivity, meaning that absenteeism would have already occurred in an increased fashion before we see a substantial impact from or the substantial increase in hospitalization data, right? So we would miss the boat in regards to knowing how to prevent productivity loss from absenteeism as a result of impact from COVID-19, right? Whereas if we are doing screening, we can pick up, and again, kind of a leading indicator fashion, when our specific local population is being affected by new cases causing absenteeism, so that we can apply the right policy, right, in place for that particular location and population. So that's the first point. The second one is population vulnerability, and we'll talk about that a little bit more here with another study, but we want to understand our population makeup because, as we presented earlier, right, there is a distinction between risk of that population and the impact of COVID based upon not just age, but also sex, right? And so if we look at our unique population makeup, that will then again inform us of how protective we need to be for that population to help prevent not just loss of life, severity, and hospitalization, but again, productivity, because our jobs, again, with wellness is beyond just loss of life, right? So again, we have to take into consideration our unique populations. And then finally, local policy preference. All right, Harris, what do you mean by that, right? What I'm suggesting is each location of your facilities are located in different geopolitical policies, meaning the government locally will have more restrictive or less restrictive approaches, right? Not something novel in terms of what we're, how we address that, right? But what we have to consider is the population at risk and transmissions in their occurrence happens the majority of the time either at home or in the general population, not at work, right? And so we have to take that into account in terms of how protective we need to be at work because of less protective measures in the general population, right? And so again, this is all part of our looking forward strategy because we will continue to have these waves, new variants, and we don't want to set a policy up where we're too restrictive when we can be less restrictive. And as well, we don't want to get caught behind the 8 ball, not having the appropriate level of protections in place and end up in a situation where we have loss of productivity because of absenteeism and tremendous impact to the workforce. All right. And so as we talk about breaking down this second point, population vulnerability, let's go back to the study I presented earlier that looked at age and sex population, because I want to take away something from this that they proposed. And I'm not suggesting we underwrite it and issue it as a part of our process, but it's a little out of the box for me, at least a little out of the box thinking in what they propose, specifically in their conclusion, based upon the differences they saw in sex and age. They propose that intervention should adapt to different ages to optimize for efficiency. That makes sense. But more so, they say the instance in this case in regards to the severity, right, and the age should predicate what the ad hoc social interventions should be, right? Again, taking into account these two factors and then applying a different restrictive policy based upon these two factors. Even more so, that general lockdown interventions, right, that are aimed to contain contagion, but they neglect the overall impact to the individuals at risk, right? And so they're suggesting that it's basically a risk-based approach to social restrictions, right? And so again, out of the box thinking at first glance, having a policy that differs for sex and age may not be attainable in our geopolitical stance right now here in the US, right? But it's something to consider perhaps in terms of what other out of the box thoughts and processes can we potentially institute to help protect those at risk, who are vulnerable, right? Because we'll need to. We'll have to, and the point I want to drive home here is that they were trying to undergird that our policies should not hinder productivity, right? And we saw that impact of that during the lockdown. And we have to be able to come up with new procedures, new policies, and institute them to protect those who are at greatest at risk while preserving the productivity and the livelihood of the individuals that are less likely to be impacted from COVID-19. And then we'll finish out with this one. In terms of duration of protection against COVID-19, this is a publication from the New England Journal of Medicine. This was just published January 27th of this year. But again, looking at something that's going to impact our population, which is waning immunity for mild and severe disease in regards to specific at-risk populations, right? In this case, looking at the UK, starting back in December 2020, right, and tracing up until there were 2 vaccines. Obviously, we looked at both. This study looks at both with regard to the effectiveness, right? And we'll fast forward so we can have some time for questions here. But in short, what this study found in regards to their methodology of looking at the 2 vaccines in England is that the vaccine efficacy decreased after week 20 for symptomatic disease, prevention of symptomatic disease. And that was at 44% and 66% for the 2 vaccines, okay? And if we look at then the 65 and older population compared to those 40 to 60, it found that at week 20, the 65 and older population had an even more significant decrease in efficaciousness, both with hospitalizations, 80%, as well as 80% and 91%, as well as with severity regarding death, right? And that was 84.8% and 91.9%. So again, reiterating that, a policy of vaccination is still the right policy to have in place or promote to help prevent severity and hospitalization and death, right? But we know that, again, waning immunity in regards to vaccination is going to happen as early as 20 weeks, right? That's less than 6 months. We have talked about, are we in a cycle of continual boosting for individuals every 6 months to maintain vaccination efficacy? Unfortunately, the data is looking as if that is going to be part of our future potentially, if we continue to have the variance and the veracity of the variants in regards to severity that uphold as they have been with Omicron and previous lineages. meaning that these variants aren't as benign as a common cold, right? Loss of life and severity of hospitalization is not equivalent for a common cold as it is for coronavirus now at this point in time. So the effectiveness we're seeing today is a factor of, or the lower levels of infection and transmission and severity is a factor of vaccinations. So again, if we are to maintain this with the presence of new variants, we're going to have to have a strategy of repeat and repeat and repeat vaccinations, right? Boosting. And until we see otherwise, unfortunately, that looks like that's how it's going to shape up. So again, a part of our policy moving forward will have to be, in addition to having flu vaccine campaigns, a continual COVID vaccine campaigns in the workplace to try to keep our numbers up in regards to effectiveness against new variants, right? All right, so I know we've covered a lot. We'll go ahead and stop there. Let's go ahead and get into questions. Thank you so much.
Thank you, Dr. Harris. Please submit your questions using the Q&A function and we'll get to as many as we can. First question, many of our company's leaders are questioning the merits of wearing masks at work. What's your advice? Is the CDC community level adequate to decide that masks can be phased out even in the midst of a surge like the one we're experiencing in the Northeast?
Sure. So in regards to the efficacy of masks to prevent workplace transmission, that paradigm has not changed. Masks do work to help prevent workplace transmissions as well as in the general community. So from a protection factor and recommendation of use of masks, particularly during periods of time like now where we're seeing increased cases, I believe is still prudent for employers to have in the workplace. Again, if our goal is to prevent spikes in absenteeism and to maintain productivity, then masks are a straightforward and simple way to help towards that end. And that's why I would stand behind recommending it in the workplace still, particularly in those hotspots.
Okay, and the next question is, what are the recommendations for the fourth vaccine or the next booster?
Sure. So currently at-risk individuals, those who are immunocompromised, those who have underlying conditions that put them at risk for poor outcome, and those older than 60 are those individuals who should be receiving the fourth booster at this point in time. It's not yet recommended for the general public. However, it is hypothesized, if you would, that come this fall, CDC and FDA may come out with a recommendation for the general population to get a fourth booster because of the data I just presented in regards to waning immunity from vaccination at week 20.
Okay, related to vaccination, people older than 60 or 65 are also advised to get their flu shot, their pneumonia shot, their shingles shot. And so it seems like a lot of vaccinations to get, and in combination, simultaneously or sequentially. What are the recommendations with regard to older people who are advised to get these vaccinations?
Sure. So as of now, there is no data that I'm aware of that precludes the vaccination administration for the vaccine, certainly that were mentioned in the question, and any deleterious outcome. Early on, we saw studies come out making sure that vaccination with flu and COVID did not decrease efficacy of either. And the answer is that there was no evidence to suggest a decrease in efficacy, nor was there any evidence to suggest an increased risk of untoward outcomes or side effects from the vaccines. So as of now, there is no prohibition for an individual appropriately in the demographic to warrant these vaccines to receive all of them without any increased risk of side effects or loss of efficacy.
Okay, here's a crystal ball question. Do you expect we'll see less and less of the population taking advantage of boosters if they have to get them every 6 months?
I 100% believe that to be the case. I know just examining the data in Israel, that seems to be partly true as well. They experienced an attrition of individuals participating, as you can see in dose 1, dose 2, and dose 3, right? So we've seen that trend here in the US in terms of fully vaccinated versus boosted. Less than 66%, far less than 66% are boosted at this point. So I do not think that trend will change and may even worsen as we move forward.
Yeah, so as it trails off, some of those people are getting breakthrough infections too, and they may think, well, now I've had it, so maybe I don't need to get another booster since I've had it. Now I have a natural immunity as well. So that might be partly a factor too.
Indeed. We know that, I've certainly anecdotally spoken to a number of individuals that that very scenario has played out, and that was a reason why they did not go get boosted. However, data still suggests that getting boosted would further decrease your risk overall for hospitalization and vaccination in that scenario, or excuse me, hospitalization and severity in that scenario.
Okay, here's a question about blood type. Is there any correlation between blood type and COVID transmission, illness severity, hospitalization, and death?
Say that one more time. Apologies, someone was knocking at my hotel
Yeah,
door.
I heard a voice.
Yeah.
Is there a correlation between blood type, COVID transmission, illness severity, hospitalization, and death?
So we saw early on that there was some association potentially between O-type blood and severity, right? Having less severity, but there's been a paucity of data that I've seen or research around blood type specifically, and that would suggest that over time we just haven't seen any clear trends around blood type, severity, hospitalizations, and death.
Have you heard of any other vaccines which may tackle waning immunity better than the current vaccines?
No, they all seem to, again, starting with the vaccines that have the highest efficacy, right? Moderna, Pfizer versus Johnson & Johnson, the waning immunity seems to be consistent, as was published in the New England Journal of Medicine paper I presented around that 20 mark.
Okay, here's a participant whose son had a sore arm injection site since receiving his booster 2 months ago. And she wants to know if there's any documentation of this occurrence in the general population.
And say that one more time, I apologize.
The son has had a sore arm since he got the booster 2 months ago, and they wonder if that's a common occurrence in the general population.
Man, I apologize. There's somebody that just would not leave my door, so you just came in. So one last time.
Want me to repeat it again?
Yeah, one last time.
Okay, the child, I don't know, that it just says my son. My son had a sore arm injection site since receiving his booster 2 months ago. Is there any documentation of this occurrence among the general population?
Yes, having a prolonged area of irritation is a side effect that is known, right? The most common side effect being just soreness for a shorter period of time, 24 to 48 hours. In some cases, you can have a local rash that's formed. In this case, it doesn't sound like, well, there may or may not be a rash associated with the soreness. If the soreness is persistent and present with movement of the, I take it was a deltoid injection in this case. But there is a condition where the inflammatory response in the shoulder, the actual capsule of the shoulder, it propagates in such a way that it causes significant and prolonged soreness. And that is a condition that, albeit rare, is documented. And I've actually taken care of several patients that have had that phenomenon occur after initial injection. It is something that is transient, meaning that it does go away, recover, but it can last 4 to 6 weeks, in some cases a little bit longer.
Okay, well, I have a question, and it's about factors that increase your risk for hospitalization, serious illness, death. So we can't control age and gender. So we see the data you presented, like the older you are, whether you're male or female may increase your risk. But what can employers be doing about management and reduction of other underlying conditions that increase risk? For example, overweight and obesity, diabetes, asthma. I mean, it seems like one of the root causes of lost work time, serious illness, and death are chronic conditions that could be potentially detected early, prevented, and or managed a lot more effectively. So this is like an ongoing underlying root cause of a lot of issues around workplace or workforce availability and the ability to work and be productive. So what suggestions do you have for employers to try to get more engagement in the wellness programs that they're offering?
Well, sure, and I'm glad you brought that up. Actually, we're going to spend the entire hour next time on that very topic, because at the end of the day, as you have suggested, and what we are mainly interested in terms of providing tool sets from work care to employers, is decreasing the overall risk factors for impact, not just from COVID, obviously, but if we do a great job of decreasing chronic disease and illness, then we have a more productive workforce. And this is the approach that has been engendered in our policy of safety to wellness, right? Where we talk about how can we keep the population more safe, and that's through wellness activities. And when I say wellness, I'm being very specific about objective measures that we can provide by way of toolkits, if you would, laboratory testing, looking at the underlying metrics for chronic illness, and offering the opportunity to modify these from workplace interventions. We are talking about, and this is kind of a teaser, allowing on-site athletic trainers that are already engaged with the workforce to participate and perform phlebotomy, to do laboratory testing on site with rapid results, so that we have higher engagement of the workforce towards participating in activities that will decrease chronic illness. Let's face it, employers are already on the hook for the most part, particularly if they're self-insured, for the underlying health risk factors of the population. And so as we seek to make the workplace that has a vested interest in the wellness of the employees the epicenter for chronic disease management, we certainly are looking to provide more tools by means and by which the employers will be successful. And again, as the teaser, we know athletic trainers with their skill sets could be a part of that. So stay tuned for next month, because we will spend our entire session talking just on that topic and look at some of the upside impacts, right? The actual return on investment, if we can increase, one, engagement around wellness of the population, and two, specific programs and the benefits thereof in regards to not just wellness, but also back to safety.
Great. I didn't know I was actually teeing you up for next month, so.
Perfect.
Good to know. We have 3 more questions. I think we can get through them quickly in the few remaining minutes we have. What is your opinion on the cardiovascular effects of the vaccine and the occurrence of palpitations post-vaccine?
Sure. So the data on the effects of the vaccine for some has been that the vaccine may increase inflammatory cardiac markers, but that increase is transient, meaning that individuals who experience that increase in inflammatory markers, cardiac markers, will not have or experience permanency to that increased potential risk. Now, again, it's there. There's evidence to suggest that after a vaccine dose, you may experience increased risk of cardiovascular untoward outcomes. But at the end of the day, the effects are transient. In regards to palpitations, again, palpitations were not necessarily deleterious in regards to any permanency to cardiovascular outcomes. If you do experience anything, we do want to communicate, right, that you should talk to your provider. But again, it's not a widespread phenomenon, and certainly rare enough in that we still recommend vaccinations.
Okay. What are your thoughts on the Novavax vaccine that's currently in the emergency use authorization process with the Food and Drug Administration compared to the vaccines that are available now?
Sure. So I have not examined the Novavax vaccine for some time. So with regard to getting a better sense of how it compares or stacks up in the data, I will dig into that, and I can present that in response to that question after this, in the next day or two here.
Okay, so for the person asking that question, we'll address that in the Q&A that we're going to post online. Next question, after testing positive for COVID, how long should I wait to get a COVID-19 booster shot?
Sure. So after your recovery, there is no predetermined wait period, right? Some have suggested that, you kind of wait until 90 days after your recovery so that you're taking advantage of the longest period of time in between either your COVID initial series or your booster, right, to have the longevity of efficacy. And certainly that's not a poor recommendation. It's just not a necessary step that you need to take in regards to waiting, right? So after you recover from COVID episode, you can take your vaccine immediately.
Okay, and the last question, has there been any connection between COVID and MS?
So far, no definitive evidence, right? Some are suggesting that the inflammatory response may play some type of role, but there's nothing that I've seen that has pointed to an actual increased risk for multiple sclerosis, which is MS, associated with the COVID-19 vaccines.
Okay, well, we'll see you back here on the 1st of June. And we hope a lot of you will join us for our May 19th webinar on heat illness and fatigue management. So not to make a bad pun, but it's a hot topic right now. And thanks again to Dr. Harris, as always, for sharing his expertise with us. And thank you all for joining us. Take care.
Thanks, everyone. And as usual, take care, be safe. God bless.